വന്നിട്ടില്ല madam.
No, not yet.
വന്നിട്ടില്ല.
വന്നിട്ടില്ല.
No.
Has started sharing, it is showing.
It has not come.
No, it's not come.
Stop share and come again.
Okay. Can you see?
No.
Oh, what is happening here?
Sharing, it is showing.
It has not come.
No, it's
Is
not
it
come.
okay? You are trying to.
Yes.
Come.
Yes, yes.
Come.
Yes.
Come. Good.
Only ചാടി വന്നു.
ചാടി വന്നു, രക്ഷപ്പെട്ടു. ഇച്ചിരി ടെൻഷൻ അടിച്ച്.
യൂട്യൂബ് തുടങ്ങി കേട്ടോ.
See?
യൂട്യൂബ്.
No.
No.
Oh, what is happening here? Okay, so now I stop sharing. It's not come.
First talk is on. First talk. Which is the first talk?
Yes.
Yeah.
ചാടി വന്നു.
ചാടി വന്നു, രക്ഷപ്പെട്ടു. ഇച്ചിരി ടെൻഷൻ അടിച്ചു. Yeah. Prasad has not joined us.
I've gone live on YouTube and now I'll start recording also.
Okay. Oh my God! The problem is Prasad is telling it is only 9:15 a.m. there.
അതിന്
What
ഒന്നില്ലേ?
to do?
I think maybe continue and let them join. Otherwise, no. Many people have already joined. No?
Yeah, I know.
8 o'clock. First, who is talking after the introduction? Who is talking?
Yeah,
After?
I will be.
Okay. So you are there.
Yeah, I am there. So now the time is 8 o'clock and it is only 9:15, means 45 minutes later if he is joining,
It'll be over by the time.
then by the time we will be closing, no? So there is the time change, whatever is there.
I think they're gone to winter time or something.
Yeah, possibly.
Yeah, something called daylight saving, right?
Yeah. So that must have started and we actually overlooked that. So shall we discuss something like
8:30 അല്ലേ?
8:15, at least 15 minutes, so that now it is 9:15 a.m. there. That is he actually replied at 7:45, so it must be 9:30 there now.
9:30 ആയിരിക്കും, correct. Just 8 o'clock, no? Half an hour ഒരു ഇതുണ്ടാവും.
Yeah.
By the time
ഓർത്തില്ല.
your session is over, it will be 30 minutes, no?
Yeah.
I think we have to honor our guests who have joined also.
Correct. Current time is 9:31 a.m. 31 a.m. the 9:30 a.m.
Yeah. Should we compromise and start at 8:15 then?
Yeah.
So a little bit early. Trump has joined. Who's Trump? Well, problems are there.
Welcome, sir. Kashi, sir.
Hello.
Welcome, sir.
Thank you.
Yeah, well, let us welcome Christy also. Christy Catherine.
Yeah.
She is first DM pediatric nephrology in Kerala. Christy, can you Can you please switch on your audio video, Christy?
Jamila madam, രണ്ട് സ്ഥലത്തുണ്ടല്ലോ.
Oh, Prasad will join now. Can you join now?
Sure.
1 minute. Let me see. So I can only join one more. He will be joining at 9.
ഇത് കട്ടാവുന്നുണ്ട്.
So what should we be doing? We will
We have
lengthen our
34 participants now.
Yeah.
yeah.
Plenty of people. But nobody from there, no, that's the problem. It's after all meant to be a sister renal center program. So the sister is not there. So like madam is telling, we can have some cultural activities or some time. Kashi sir. Sir is there. Kashi sir. Yeah, it's there.
So if we were starting at Christy, hi Christy.
And ഇവിടെ ഉണ്ട്.
Hi, sir.
Okay sir. Chako sir വന്നില്ല അല്ലേ?
ചാക്കോ സാർ എത്തിയിട്ടില്ല.
I think participants will start dropping out because it is dinner time and all.
Yeah, I know. So we will start. Yeah.
Shall we start then? What about Prasad? Is joined?
No, Prasad has not joined. Prasad will join only in another 15 minutes.
50 or 15?
50.
50, it's a long time.
Yeah, it's a long time. Actually, he replied at 8 o'clock that he will join in 1 more hour. And I think we can only join at 10:30. That is what he has written. We have put the time, their time as 10:30 only. It is, these people are very, very particular with, they are not flexible.
Yeah, time.
Yeah, we have put it as 10:30 a.m. Yeah.
Now it's, if it is 10:30 a.m. means by the time our program will be completely over.
Yeah, it will be over.
That's going to be very difficult.
So we will drag it a little bit.
Yeah. We can do
We'll
that.
have some discussions and
After your presentation, maybe because it is very relevant.
yeah, we will talk about everybody.
Yeah.
We prolong it. Yeah.
And we can
Madam,
start
we
then.
will start then. I think it is 27. We will start in another 10 minutes, Sadish. We will start at 8:15.
8:15 we'll start.
Yeah.
So to all those who have joined just now, please note that we'll be starting at 8:15.
Yeah, we do apologize. There is some, because it is a sister renal collaborative program. We have to have our sister joining from US. And the
summertime problems.
Changes. Yeah. So there is a little confusion when we calculated the time. We were in summer still. And today we are having a very interesting topic, and I think everybody can discuss whatever is their experience on this issue that we are all facing together.
So, what do you feel about school reopening? Do you think school should reopen or should remain shut down?
I think it should reopen. What is your opinion, Madam? Elizabeth, ma'am?
I think in a phased manner. You can start 10
Phased,
and
yeah.
and even the batch can be split into two. One day, one batch can join. The teachers
Yeah.
will have to do it again. That is what we are doing in medical school. Medical college is starting, but the teachers may have to do it again. That is.
Yeah. So the workload. Yeah.
The school one should be facing in the classroom. So put them into A batch, B batch, and let us try with 10, then 12, and then see how it is. If a third wave is coming into more disaster, we will decide, okay, we will not bring the kids in this year. Otherwise, we can. Suppose it is not going to be a disaster, it is going to work, we should at least bring them to the school. Now there is a saying that at least for an excursion, take us to our school. We want to see our school. The children are coming. They are so much missing their school and their teachers.
The other thing maybe to
And
have.
what about all medical colleges?
Yeah, 50% attending school, 50% from Zoom at home. May change every day. One batch attends today, another batch attends tomorrow. Then maybe another. And the other people sit at home and do on Zoom.
Something like that we'll have to do. Split them into two batches.
Yeah, the life has changed so much now. We are all so much, even though we are all there, we are not there. Yeah.
Everything's changed.
Yeah.
Previously, when somebody wears a mask and walks, you think it's either a transplant patient or an oncology patient. And nobody else used to wear a mask. Now,
why the child is wearing a mask and all, you know, and a child is wearing, is he on some oncology treatment?
now if you don't wear a mask, you wonder what this fellow is doing.
In Mongambia, we are starting from Monday onwards. All our students have joined with a negative certificate, and then they were put to 5 days quarantine from Monday to Friday. Saturday again they will be the test will be done again, and after that Monday onwards we are starting. Dr. Bennett's son is there. Elizabeth Madam's granddaughter is there. So maybe we can get more feedback from parents also. Otherwise, you know, we don't know who are the parents. So Dr. Bennett is there. So we have planned, the NMC says the exam should be in April. That means hardly 24 days posting in medicine, 24 days pediatrics, 24 days surgery, obstetrics, like that we have planned, including model exam to be over by March 30th. And they may get 1 day. Then somebody was asking, what about study leave? Then our principal was telling 8 months they had study leave. No more.
Yeah.
If the medical council says exam is postponed, then they will get study leave. We are gearing up to do it by April. And I think first MBBS has to be done in February. So they are doing
February.
Morning and afternoon lectures and practicals in the afternoon.
Their classes are starting on February 1st, I think. February 1st. First MBBS. Actually, people who have maximum suffering is for the final year MBBS students. They are having no unique exposure.
And one thing good about MGR University is that from 2015 onwards, we don't have additional batch. 2015 after first after 1 month, they gave the save a year exam. And many passed the exam. The teachers say the students transform because it is their final chance to go with their friends to clinic.
Okay.
And they had to wait for the next batch. So we don't have additional.
Yeah.
But in Kerala University, now they started means another 5 years for the additional batch to disappear. We started in 2015, so we didn't have additional batch. That was a big boon for us. That means otherwise, you know, now some exam is conducted without, they didn't have any posting. We don't know. the additional batch. 1,000 students were there in the additional batch who never had any posting. They did the exam.
Yeah, even internship, as well as the postgraduate program, people are getting COVID postings only, most of it. No clinical real posting for even not the postgraduate students are, they are also not having exposure in their respective departments. That is happening only, means off late only as the COVID cases are going down. This is actually becoming, the posting is actually getting resumed.
NMC has said that 50% beds should be non-COVID now. COVID 50%, non-COVID 50%. We stopped taking COVID.
Yeah.
I think Kanyakumari districts don't have much COVID. So no patients are coming even, no inquiry is there for admission also. We stopped. But pediatrics, very less patients. Other departments are picking up better than pediatrics. I think the minor ailments are all not seen these days. Only some
respiratory infections have come down drastically, and because of the mask must be.
Immunization has started coming. Immunization. I think we can start 8:15.
Yeah, we will start, madam. Yeah, madam, you can start with the program. Yeah. Welcoming everybody to this SRC meeting.
Good evening, one and all. A warm welcome to this wonderful collaborative webinar. I have great pleasure to be part of this, and my greetings to the esteemed partners, Mr. Concern, faculty, organizers, delegates, and invited guests. Vimala ma'am is here, Kashi sir, Dr. Bennett, Dr. Susan, Dr. Sadiq, Dr. Radhika. I am pleased to recollect that the partnership between the International Society of Nephrology, ISN, renal collaboration between our prestigious SAT hospital and the renowned Cincinnati Children's Hospital started way back in 2018 at level 3. I think the host can mute the other noises. The CME program and workshops conducted by Dr. Susan and her team so far had been appreciated by everyone. I was fortunate to be part of it year after year, and I have seen the collaboration growing and bearing delicious fruit. This has helped the department at SAT Hospital to closely follow the pediatric nephrology department at Cincinnati as a model for further expansion and development. I am happy to share that ISN has now upgraded the program at SAT Hospital to level B in 2020. COVID-19 is a multi-system disease, and it is not simply a flu-like illness. I think we made a mistake initially thinking that it is highly-like illness. And we understand that acute kidney injury sets in COVID-19 in many patients, leading to the need for dialysis. COVID-19 patients are twice as likely to develop AKI as compared to non-COVID patients. In a big study, it was said that the COVID patients, it was 56.9% versus 25.1% in the non-COVID. AKI appears to be a marker of COVID-19 infection severity, and the mortality rate is higher for these patients. We have heard a lot of webinars on this, but most of it is from the social media knowledge or bookish knowledge. But it is worth listening to a first-hand information from our own team from SAT Hospital. So that is what Dr. Susan is going to do now. This pandemic gave us a mix of hardships, but also partnerships, and taught us how to come closer, sitting apart, as we are doing now. Sharing and learning on virtual platforms has become the norm during the pandemic. Today's webinar is incredibly unique as stalwarts in the field of nephrology and practicing pediatricians are coming together to cherish this academic feast. We have with us two international luminaries in the field of pediatric nephrology, Dr. Prasad Devarajan. He has been very kind to come physically for all our conferences previously, and Dr. Mark from Cincinnati Children's Hospital, along with renowned national speakers. I wholeheartedly welcome all of you to this great event. And I think now I invite Dr. Susan to carry on the proceedings and enlighten us on the SAT experience. Thank you very much.
Can you see the slides? Can you see the slides?
Yes, yes, yes.
Okay, so this is actually the third this ISN Sister Renal Center collaboration webinar that we are conducting. And we started off in June, July, because the International Society was asking that this a lot of programs were planned, but everything had to be, we had to postpone it or cancel it because of everybody, all of us are knowing that it is because of this COVID-19, which has come in March. It started off actually in December 2019, and they're spreading throughout the world, visiting us from March. And all our life, and
Dr. Susan, Dr. Susan,
hello.
Your strength net connection is low, I think. So you switch off your video so that your audio will be better.
Okay then. Okay, madam.
Your screen is also gone, Susan. You have to get it back.
Continue with your presentation.
Now it's coming.
The video off.
Okay, madam.
Yeah, now it's fine.
This is a major global human threat, all of us know. And this is characterized by, it is also called SARS-CoV-2, which is primarily manifesting as an acute respiratory illness with interstitial and alveolar pneumonia. It can affect multiple organ systems in the body, including heart, kidneys, digestive tract, blood, and nervous system. It first emerged in Wuhan in China in December 2019 and is now declared as a global pandemic. All these things we all know. The first case of COVID-19 pandemic occurred in Kerala. Actually, the first in all of India. Kerala is first in most of the things, and this also, we were first. It was confirmed in Thrissur on 30th June 2020. And from then, you can see that the graph is steadily going up and our caseload is increasing. And right now we are having actually nearly 5,000 new cases per day, and we hope and pray that our percentage will be coming down from 10% to very low so that all of us will be safe and sound. So the COVID-19 is actually considered as an adult disease with lot of mortality and morbidity in the adult population. And we all thought that children may not be affected, or children may be affected. Very mild affection may be there in the initial few months, but slowly we realized that children are also getting affected, and the pediatric multisystem inflammatory syndrome, which is there, which is actually mimicking the Kawasaki's disease, it has come and is affecting a lot of kids and producing sequelae even. COVID-19 is actually reported in all age groups. 1 to 5% of diagnosed cases actually is occurring in kids, and kids are generally asymptomatic. 10% will have a mild flu-like illness compared to adults, and the case fatality rate is actually very low in children. And actually initially the positivity was actually associated with a lot of alarm for the family and for the society, and we all know the amount of that people were getting flocked to hospital, and our hospital was also getting filled up with all the COVID positives, so that the non-COVID case load was coming down, and the people with non-COVID issues were actually denied proper care because of the overflowing COVID-19 cases. As the time passed, as the months slowly moved from March to September, August, September, October and all, we started seeing a number of children with clinical features of toxic shock syndrome coming to our hospital also. And the reports were coming from all over the world as well. And atypical Kawasaki disease, like symptomatology, children were positive for COVID-19. And in US, this is called multi-system inflammatory syndrome associated with COVID-19 or MISC. And in UK, it is pediatric inflammatory multi-system syndrome temporarily associated with SARS-CoV-2, that is PIMS-TS. This is a new phenomenon we have not seen before, affecting previously asymptomatic children with SARS-CoV-2 infection. It manifests as hyperinflammatory syndrome with multi-organ involvement, similar to Kawasaki disease or toxic shock syndrome. It affects the myocardium, and the children will be presenting mostly with shock and subsequent multi-organ dysfunction. And the sequelae is dilated coronaries. And so today, I am not going to talk in depth about MISC, its manifestations, its management, or its sequelae. We will be concentrating more on how COVID-19 infection in children is affecting the kidney. So our topic of interest for today is COVID and kidneys. Current information on kidney involvement in patients affected by COVID-19 is scarce. Incidence of AKI in critically ill COVID-19 patients is actually reported, the range is 5 to 19% with a prevalence of urea and hematuria. Even 40 to 50% of adults with COVID are reported to have proteinuria, hematuria, and various the reports from all over the world, this case series, they're telling that the incidence of AKI in critically ill may be even going up to 40 to 50%, even 60%, and requiring the renal replacement therapy and all. And it is actually contributing to the morbidity and mortality of patients. The current pediatric data, however, available is mostly anecdotal. We are having only few reports from elsewhere in the world. The diagnostic findings, clinical course, and the treatment are similar to that of the adults. Only 0.6% of the pediatric cohort has been reported to be critically unwell with severe symptoms during COVID infection. Acute kidney injury can occur or develop as part of this multi-system involvement, probably secondary to low cardiac output state or because of the vasculitic process that is occurring, or both. And it is also a known complication in the Kawasaki-like disease, which is reported in almost 30% of the patients with MISC. And so today I am not going in depth into how COVID-19 is affecting the kidneys, because Dr. Satish will be dealing with this at length. But just before we delve into the COVID experience, in the kidney experience in COVID patients, we will just look at the mechanism of renal injury. In a nutshell, the potential mechanisms can be discussed under 5 main categories. As all of us know, dehydration, renal factors operating is the most important cause. There is decreased fluid intake. There is this child may be vomiting, will be having diarrhea. Then to keep the lungs dry, people may be overusing diuretics. So this all will lead to a hypovolemic state. Then the cytokine storm syndrome, high concentration of interleukin-6, especially in people with ARDS. And AKI can occur due to renal inflammation, increased vascular permeability, third space loss, intra-abdominal hypertension, hypovolemia, and subsequent shock. Then in any multi-organ dysfunction syndrome, we talk about organ crosstalk. Aggressive ventilation with severe hypoxemia, hemodynamic instability due to cardiomyopathy or myocarditis, exacerbated by the aggressive volume replacement, positive fluid balance, or co-infection with secondary bacterial infection with subsequent sepsis and septic shock. That may also contribute to renal injury. Then SARS-CoV-2 virus can directly attack the proximal tubules, podocytes, as the spike protein is having the angiotensin II receptors in the kidneys as well. Then the nephrotoxic drugs, not to forget about them. We may be using drugs which can again injure the kidney. So these are the various mechanisms. So we have tried to analyze COVID-related renal disease as well as COVID in children with pre-existing renal disease
And what is the outcome in such children admitted to SAT hospital from March 2020 to October we have analyzed. We will start with the stories of two kids with COVID-19 illness, one with pre-existing renal disease and other with de novo normal kidneys. I invite our host MD resident, Dr. Dicky, for the presentation.
Thank you, madam. Can you see my slides? Is my slide visible? Hello?
Yeah, you go to the slide projection mode.
Can you see?
Yeah, we can see. Go to the slide projection. Yeah, we can see.
Okay, madam. Today I will be presenting two cases. The first case is that of a 5.5-year-old female child. She is a known case of primary steroid-resistant nephrotic syndrome and on regular follow-up. She presented to us at 1 year of age with a nephrotic syndrome, and in view of her primary steroid resistance, we did a renal biopsy. And the renal biopsy that time showed 19 glomeruli, out of which 26% were obsolescent, which were small and globally sclerotic. And there was tubular atrophy in less than 5% with the surrounding mild mononuclear infiltrate. The interstitium and vessels were normal, and the immunofluorescence was negative. And the diagnosis was given as a moderate global glomulosclerosis in the background of near normal glomeruli with a negative immunofluorescence, and FSGS could not be ruled out. So we started her on cyclosporin at a dose of 5 milligram per kg per day, and we adjusted the dose according to the serum trough level, and we slowly tapered the steroids, and she was maintaining partial remission with cyclosporin and low-dose prednisolone. Over the last 4 years, she remains normotensive with an euvolemic. Our height was in the 25th centile with a growth velocity of 6 centimeter per year. She had no cataract or glaucoma, and she was non-diabetic. And her serum creatinine 1 month prior to her admission was 0.6 milligram per deciliter with a GFR of 74%. And on September of 2020, she was admitted with generalized edema. At admission, her vitals were stable. She was afebrile, found to have ascites, and her BP was in the 90th centile, but she maintained urine output of more than 2 ml per kg per hour. Her investigations revealed that she was anemic with an HB of 8.7 milligram per deciliter, which were normochromic normocytic RBCs. She was found to have acute kidney injury with a GFR which has decreased to 55.7%. She was hypoalbuminemic and her cholesterol was elevated. And the kidney ultrasound done at that point of time showed a normal size kidney for age. The echogenicities were increased in both the kidneys, but the corticomedullary differentiation was maintained in both the kidneys. And she was managed with a 2 milligram per kg of prednisolone, IV albumin infusions, and we started her on broad spectrum antibiotics pending cultures, and we had stopped the cyclosporin in view of the AKI. And unfortunately, on day 10 of admission, she as well as her mother, they both developed fever and both were tested positive for COVID-19. Her fever was associated with rhinitis, but then subsided within the next 2 days. She was given a 5-day course of oral azithromycin and oral prednisolone was continued. And on the 12th day after being tested positive for COVID, she developed swelling over the right arm as well as the right side of the chest. And that time we suspected a thrombosis. So we did a D-dimer, which was found to be elevated. So we started her on low molecular weight heparin, and subsequently we added warfarin as well. But however, we did a Doppler study, which shows normal venous system of the right upper limb. And after starting the low molecular weight, her swelling subsequently subsided after 4 to 5 days. And we adjusted the warfarin dose to maintain the INR between 2 to 3. And also we did an echocardiogram to rule out any thrombus or any coronary dilatation, which was found to be normal. At this point of time, she continues to be non-oliguric, but her renal parameters deteriorated further. And she was found to have microscopic hematuria on urine analysis. And the complement C3, which was sent at that point of time, was found to be low. And these are the investigations which we have sent during her admission. You can see that the blood urea and the serum creatinine slowly rising over time, and the GFR progressively declining. And she continues to be severely hypoalbuminemic. And as I have already mentioned, she had microscopic hematuria with a low complement. That was on day 18 post-COVID infection. But at this point of time, clinically, she was stable. Her edema did not increase. She was non-oliguric, and her BP remained stable. She was normotensive. And if you see the renal parameters, her GFR was more or less the same. As she improved clinically with the conservative management of AKI and her edema became better, she was discharged after 4 to 6 days of admission with a GFR of 26.3%, and conservative management of CKD was continued. During her hospital stay, her electrolytes was always normal. She never had hyponatremia or hyperkalemia. And the ultrasound taken during her this illness showed normal size kidney for her age. Apart from the increased echogenicities, the corticomedullary differentiations were maintained. And the diagnosis was primary steroid-resistant nephrotic syndrome on cyclosporine and steroids, acute COVID-19 infection, acute kidney injury on chronic kidney disease, and suspected venous thrombosis of the right upper limb, which could be due to the nephrotic syndrome itself, or it could be due to the COVID-related complications. And the acute kidney injury could be attributed to the pre-renal factors or the CNI toxicities, or it could be due to the COVID-19 infection-related glomerulonephritis. As the patient got better, we discharged her on tapering dose of steroids and continued on injection erythropoietin and supplements of iron, vitamin D, calcium supplements, and phosphate binders. And on follow-up, we did a renal biopsy to assess for the chronicity as well as for the CNI toxicity, as her protocol biopsy was also due, and also to rule out the acute worsening factors secondary to COVID infection, as well as the possibility of IRGN was considered, considering that she had microhematuria and a low C3 level and a deranged RFT. But the biopsy that we have taken, out of the 23 glomeruli, 30% were obsolescent, which were globally sclerotic, and segmental sclerosis was found in 7 glomeruli, none otherwise specified. And there was no endocapillary proliferation or crescents. The tubules shows epithelial vacuolation, simplification, and hyaline cast in RBCs. Tubular atrophy and loss were seen in 30 to 40%. Mild mononuclear infiltrates and interstitial fibrosis were seen, and arteries shows hyperplastic features. Immunofluorescence was otherwise non-specific, and the diagnosis was given as focal segmental glomerulosclerosis, none otherwise specified, with a non-specific immunofluorescence with moderate global glomerulosclerosis, moderate chronic interstitial fibrosis with tubular atrophy and hypertensive changes. So in view of the renal biopsy suggestive of the progression of the FSGS, we continued her on conservative management of CKD after withdrawal of the immunosuppressive medications. And on follow-up, she remains normotensive and she's non-oliguric, and her serum creatinine has improved to 1 milligram per deciliter, and her GFR has increased to 44.6%. Her HB also improved to 10.3 gram per deciliter, but she remains to be high-grade proteinuria.
So shall we, Dicky, shall we stop here and let us have some discussion on this problem?
Okay, madam.
Yeah, Satish.
Yeah.
Yeah, we welcome Dr. Prasad Devarajan. He has already joined.
Yes. Good evening, Dr. Prasad.
Yes, thank you. Sorry, I was a little late.
Yeah.
We actually
No, I think that's a very interesting case, but I just wanted to clarify the first time, was it minimal chain disease or was it FSGS that time also? It's not very clear.
There was a glomerular sclerosis, but FSGS could not be ruled out. That was
the first biopsy,
the first diagnosis. That one only, sir.
Yeah, Sadish, actually the first biopsy was at 1 year. At 1 year, and it was reported as actually the whatever glomerulus we have projected, it is actually showing some focal sclerosis at the pole, but the report that was the glomeruli which were actually of normal size was actually normal, but there were some small glomeruli which were small in size and globally sclerotic, and there was some interstitial fibrosis, tubular atrophy to the tune of 5%, and so they have reported it as mild global glomerulosclerosis, and interstitial fibrosis and FSGS cannot be ruled out. That was what. There was no vascular change, And there were no glomeruli which were actually showing a real focal sclerosis.
Okay. I think then this looks like a quite severe chronic changes, no? Compared to the age of this child, we don't expect this much of 30% glomerulosclerosis and a reasonable amount of IFTA. So I think the progression is not going to be good. And this doesn't look like a CNI toxicity. It looks more like progression of an FSCs.
And now the child is 5 years down the line and is having, and the good thing is that she never had hypertension. We never had to give her antihypertensives, and her proteinuria was never, she was in complete remission. She was having ongoing proteinuria. And one thing which we have not done is a genetic study on this child. She was showing some partial response to steroid and CNI. The proteinuria was coming down. Genetic studies are not done in this child. Prasad, for your comments.
So yes, if a patient is steroid responsive, we certainly will not do genetic studies. But if a patient is steroid dependent or frequently relapsing with a clear picture of FSGS, we think it's advantageous to do genetic studies just in terms of preparing for future transplant. Because as you all know, certain forms of FSGS rapidly recur in a transplant if the patient progresses. But the genetic forms don't, so we don't have to worry about that.
Yeah.
And any comments on the low complement which was there during the COVID? Because we actually had one or two patients with low C3 complement and microscopy hematuria during the COVID episode, and we were thinking whether we are dealing with an infection-related GN in these cases. But this girl, the biopsy is not showing any feature suggestive of a proliferative change, or some C3 complement was there in the sclerotic areas with that in interstitial fibrosis, tubular atrophy, inflammatory areas, but it is reported by the pathologist as non-specific. Actually, glomeruli were not showing any C3 or IgG for that matter. And so we actually did C3 complement in few of our other children who were presenting with COVID, and we found that the C3 is normal in them. So we could not explain the low complement. And what is the opinion of the everybody's opinion, Prasad and Satish and Vimala madam and Kashi sir?
Yeah, actually, one of the things is that COVID itself predisposed to complement abnormality. There is abnormalities of alternate, and I'll be talking about that shortly.
Okay.
So it is there. So that may be part of it. So you're not really sure, because this biopsy definitely did not show any features of proliferative glomerulonephritis. No? It looked more like it looked definitely like an FSGS picture. So it's unlikely the complement is fitting into the clinical or biological or the pathology behind it. Prasad, any ideas?
So in COVID patients, we've seen complement go up, complement go down, complement stay the same. We don't understand COVID. I'm sorry. We're far from understanding COVID.
Yeah. Carry on. Somebody unmuted.
Yeah, okay, Vicky, you can now go ahead with the second case.
Okay. And coming to the second case, he's a 12-year-old boy, apparently normal, and he was admitted with complaints of high-grade intermittent fever and rash all over the body for 5 days duration. He had diarrhea and vomiting for 3 days and a decreased urine output of 1 day duration. At admission, he was found to be in respiratory distress. He was in shock, and subconjunctival hemorrhage and ecchymotic patches were seen all over his body. And our initial clinical impression was sepsis with multi-organ dysfunction and coagulopathy. And the possibilities that we initially had were dengue fever, as we are living in an endemic area, as well as bacterial sepsis. And also in regards to the current pandemic, we were thinking of COVID-19 related multisystemic inflammatory syndrome. But there was no history of contact with COVID-19. And his investigation showed that he had a neutrophilic leukocytosis with a normal platelet count. His inflammatory markers were elevated. His TROP-T and pro-BNP were also elevated. His INR and D-dimer were also elevated. He was found to have acute kidney injury as well as acute liver injury. He had hyponatremia, hyperkalemia. His blood gas shows metabolic acidosis with a high lactate, and his COVID-19 gene expert came positive, and as well as his dengue IgM. He was in shock and he required multiple inotropes, and he also need support, respiratory support, needing invasive ventilation, and his acute liver injury progressed to acute liver failure. And we started him on broad spectrum antibiotics, and in view of the COVID positivity as well as the high inflammatory markers and the multi-organ involvement, we started him on methylprednisolone pulses for 3 days, which was then followed by 2 milligram per kg of oral prednisolone. We could not give antiviral as he had an acute liver failure. And for liver failure, we were also giving supportive measures. He initially had an oliguric AKI at admission, but it gradually improved with our fluid resuscitation and inotropes. So we continued with our conservative management of AKI. And we were able to extubate him on day 4 of admission, and inotropes were stopped by day 5. These are the list of investigations that we sent during his hospitalization. We can see that in the initial days of the admission, the renal functions as well as the liver enzymes are highly elevated. But after correction of the shock, they gradually became normal. And he also developed, on day 3 of admission, he developed a macroscopic hematuria, which was polar colored, but there was no oliguria at that time, nor hypertension. And his urine analysis shows plenty of RBCs. His urine culture was sterile. And we did a complement level that time that was low. And for the hematuria, we were considering the following possibilities. The first we considered was because of the acute tubular injury. And the second one was because of the acute liver failure and coagulopathy. And the third one was it could be due to the COVID infection-related glomerulonephritis. And the final diagnosis that we have come up with was acute COVID-19 infection with the multisystemic inflammation, cardiogenic shock, acute liver failure, and also the possibility of a mixed infection with dengue, as the dengue IgM was positive. He had an acute kidney injury with a Kedigo stage 2, which was non-oliguric. And the AKI could be attributed due to the multi-organ dysfunction with acute tubular necrosis as a part of the multisystemic inflammation itself, or it could be due to the COVID-19 related glomerulonephritis. And we could done echo by day 11 of admission, where the coronaries were found to be dilated. Unfortunately, we were not able to start aspirin that time because he had his liver functions were deranged. So initially we started him on a low molecular weight heparin. Then later we shifted back to aspirin as the liver function improved. The patient improved, his renal function normalized, his hematuria cleared. So further evaluation like renal biopsies were not done. And the patient was discharged on day 19 with a low dose aspirin. That's it. Thank you.
So a very interesting case, I think. One of the big things is that early treatment is important in all these cases. No? That's where the improvement occurs. So actually you treated with steroids initially?
Yes,
yeah, he was
methylpred bolus pulse doses.
Good. Yeah. Just before we go into this case, there was one question Dr. Sangeeta has asked about previous case. What happened after that C3 level did come down after the episode? The first case, no?
Yeah, we have to still, because the time of 6 weeks is not over. But since it is not an IRGN, we will repeat it as she will be coming for the next follow. Yeah, it is actually, it is not repeated.
Actually, it may not make much difference. Also. Even if it comes up, we are not still sure whether it was an IRGN at all, because it might have been due to the COVID that it went down and then it came up again. So really it doesn't help much. Only if it remains low, then maybe we can think that something is going on. And about this type of cases are becoming more and more common. That's what about this multi-system inflammatory disorder. And the key, I think, is to early diagnosis and treatment. So we'll be talking about that also to some extent. Any other questions or anything? Dr. Prasad, anything to say about this?
Any specific anti-COVID-19 treatment that you did in this patient, or you guys do in general?
Yeah, we are
actually,
using
we gave only that. Yeah, we couldn't give him because of his liver enzymes were going to the tune of 8,000, 10,000, 19,000, and his prothrombin time was also 2. PTINR was 2.4, and he was also having bleeding manifestations. So we were not giving him any antiviral drug. We just supported him and give steroids.
Yeah. I think most of us are using remdesivir and steroids here. And remdesivir, when used early, I mean, clinically it looks like it's beneficial, even though the studies have shown that it's not effective. It's there.
What is your experience, Prasad? Any?
Yeah, I agree with Satish. If it is given early, it seems to be effective. It worked in President Trump's case, as you know, and in many other cases. But if it's given late in the course of the illness, it does not seem to work.
That is there, yeah. Any other questions? Anybody? Comments?
Kawasaki disease usually occurs in younger children below 5 years. That's Kawasaki associated with this one is in older children. So the second case, we can think of it, but the first case is too young to be Kawasaki associated or COVID associated Kawasaki. In older children, it is usually in adolescents and in other places, it is reported like that.
Yeah. Yeah, we agree with you, sir.
Yeah, yeah. Anybody else? Dr. Kashi sir or Mimala madam? No other comments? Susan? What's next?
Yeah, we will go for the next.
Is it my presentation next?
No, it's my rest of it. I will be. Yeah, I will start the screen share. So can you see my slides? Can you hear me? Yeah. So we are, as I have told you, after that 2 interesting problems that we have faced, and we will be going to the COVID-19 experience that we had in SAT hospital in the past few months. So the total COVID-19 positive admissions from March to November 2020 is 625. And the mean age of these children were they were 4 plus or minus 3 years, and the male-female ratio is almost the same. We had 2 neonates with COVID positivity, as well as 11 infants who were COVID positive. And it was in the infancy, what we were seeing was they were mostly presenting with respiratory symptoms, breathlessness, diarrhea, and vomiting and as well as febrile seizures. That was the common presentation that was seen in infants. And we can see that the asymptomatic COVID positivity is almost 1/3. This is because in the initial few months, when COVID was creating a lot of alarm in the society, whenever a positivity is diagnosed, the families will be totally coming and getting hospitalized, and all the kids also get hospitalized. So 198 children who were positive for COVID, they were totally symptomatic. And the category A mild symptoms were there in 14%, and this category B 44%, and category C there were 30 children with category C, and 9 children were having MISC along with a positive COVID. And post-COVID multisystem inflammatory syndrome was seen in 18 children. So our multisystem inflammatory syndrome altogether, we were having 27 kids with MISC. And so we will be analyzing only the symptomatic COVID, that is 427 kids, that is contributing to 68.3% of all the COVID positivity. And as I have already told you, category A, B, and C we have discussed. And the commonest symptom was fever in 72% of children, and the respiratory system involvement with rhinitis and minor respiratory illness was there in almost 32%. And the MISC children were having more breathlessness and requirement for respiratory support and all. The diarrhea and vomiting actually was there in 17%. CNS, liver, and renal involvement were to the tune of 2 to 5%. You can see that the renal involvement per se, the acute kidney injury, when you consider in all the symptomatic patients, we were having only 2.1%. So in this discussion, I will be talking about these symptomatic COVID positive children who we had to think of the kidney, that is in 5.3% of children. And this was actually some children, the pre-existing kidney disease was there, and those kids were getting COVID infection. They were 15 in number, whereas COVID infection occurring in de novo normal kidneys and acute renal injury occurring in 8 kids. So let us see how these children are going to fare. And so first of all, we will discuss the COVID-19 in children with pre-existing renal disease. And we had children with nephrotic syndrome as well as children with chronic kidney disease presenting with COVID positivity. And nephrotic syndrome, actually, the one child who presented with the first episode, there were no atypical features, but she was positive for COVID, and then we were confused as to whether to start the treatment with steroid, because it was in the initial few months, we were not sure whether steroid is going to do harm or good. But since she was not having, she was totally asymptomatic, we actually started her on steroid and she responded. And then steroid sensitive nephrotic syndrome in remission, 2 children presented, and they were actually not having, they were not on steroids, they were off steroids, and they had COVID positivity, again asymptomatic. And then steroid dependent nephrotic syndrome on MMF, still not doing well. We were planning to give rituximab. We had already given the first dose of rituximab. He went home and came back next week for the next dose. And when we tested him, because prior to admission, we were testing all children as a routine measure, and he was positive. And we were little worried about this positivity, because we had already given him rituximab, which is a really strong immunosuppressant. But luckily, this boy actually didn't had a severe manifestation. He also had some little fever and rhinitis, and he became better. And then this primary steroid resistant nephrotic syndrome, I have put it as 2+1, because the one child is the child who is already, we had presented, who was having a worsening renal function and an episode of thrombosis, and she was in the hospital for almost 46 days. The other 2 steroid resistant nephrotic syndromes on immunosuppressants, that is steroid and CNI, they were actually not having a serious complication or due to COVID infection. And all these children, we actually continued immunosuppressive medications. And now let us look at the chronic kidney disease kids who had COVID positivity. They were this 8+3. 3 is that SRNS, which is in the nephrotic syndrome category as well. So 8 children with chronic kidney disease in different stage of CKD. The stage 1 CKD, the SRNS, 2 of them are included in the stage 1. So we will not talk about them now. There was one child who presented with multisystem inflammatory syndrome. It was an 8-month-old baby who had a rhabdomyoma, and she had one kidney nephrectomized. So she was having a single kidney. She was presenting with multisystem inflammatory syndrome. Luckily, she was not going into requiring ventilatory support or inotrope support, or she didn't develop any acute kidney injury during that episode. She actually had a relatively stable course and got discharged. And then this, we had already presented that child who was having CKD stage 2 with AKI and worsening of renal function. We had already dealt with that baby. And then there was one child, CKD stage 3. He was having a neurogenic bladder he was on CIC, but he also was totally asymptomatic, and because he was having CKD3, we admitted him, and he was also going well. And then talking about children on dialysis developing COVID, then that was 3 kids who were on maintenance hemodialysis. It was becoming a real issue, because how to maintain them on dialysis, how to dialyze them, and we had to actually send them to other COVID positive dialysis units for dialysis, because we were not having the facility to isolate, and so it was becoming an issue. But clinically they were also doing okay. And 3 children who were on CAPD also had COVID positivity, and they also didn't develop much complications. So you can see that pre-existing renal disease, as we talk in the adult, the comorbid illness which is there is going to be a real problem, increasing the morbidity as well as mortality in COVID-19. But pediatric age group, children with chronic kidney disease, even on dialysis, our experience is that we were luckily not having much issues with COVID-19 positivity. And then we will be asking why you tested them, because in our unit there was a
we have presented that child who was who was having that steroid resistant FSGS. The mother and the child developed fever and became positive while in the ward. And then we tested everybody in the ward and many of them became positive and we had to close down our ward. And so this, because of the primary contact, many kids got tested and they were positive, but they were not symptomatic. So pre-existing renal disease, we have already presented. Mortality is nil, and symptomatic COVID occurred in only two of the children. One was MISC and other was the SRNS who had AKI, and mortality was nil. So now let us proceed to pediatric COVID in de novo normal kidneys and AKI. That is the problem. The total number of acute kidney injury was only 1.4% when we take the 625 inclusive of the symptomatic as well as asymptomatic kids. Whereas in the symptomatic COVID, we can see that it is only 2.1% in our series. And in the ICU, 7 out of 50, that is 14% had AKI. And in the multisystem inflammatory syndrome, almost 1/5 of children, 20% were having acute kidney injury. And most of them, majority were in stage 1 as pre-renal and improved with fluid resuscitation and inotropes. And stage 2 AKI was there in 2 and stage 3 in 2. And this AKI stage 3 was seen in children who were both in the multisystem inflammatory syndrome. And all had non-oliguric AKI and they were all managed conservatively. And the renal function improved with correction of volume and cardiac status, and all recovered except that one with the pre-existing chronic kidney disease who is also slowly going to have an improving serum creatinine from 1.7, it is coming to 1 milligram. And so that is, we are expecting, she is having a chronic illness and possibly she may stabilize at around 1 milligram. And the mortality is nil is the good news that we have to say. And so 1.8% of children with COVID, symptomatic COVID had an AKI, and AKI in ICU was 14%. And one child actually with MISC, there were 7, and without MISC, there was 1. This child had a this cyanotic congenital heart disease who was positive for COVID. And then she had developed suspected thrombosis because she developed a stroke and had to be given contrast for CT. And that actually triggered the AKI, from which she recovered without dialysis. And so this, when we compare this with the adult data, the IP admissions, if you consider it, is almost 7%, and in intensive care unit, almost 1/4 of patients were having AKI, and proteinuria and hematuria were to the tune of 44% and 27% is the adult data available from this Lancet publication that I have taken. And this is actually proteinuria and hematuria in our series. Children with AKI, we had seen hematuria in 2 kids, as well as those 2 kids were having this subnephrotic proteinuria, mild proteinuria. It was not a great proteinuria that we could see in these kids. So this is a comparative data analysis that we have done. That is this in the Great Ormond Street Hospital, London. They have reported 52 kids 0 to 16 years. And ICU, where 93% of children in the ICU had AKI, indicating that in UK, possibly the children were also very sick. And MISC, they're 78%, whereas you can compare it with the percentage that we have projected for the 50 children 0 to 12 years in the pediatric ICU in SAT hospital. The stage 3 AKI also. So all the possible features of AKI as well as the severity, you can see that it is much, much better compared to the UK data. In UK data, they found that diarrhea and vomiting were a predisposing factor for AKI in almost 50 to 70% of children. We also found that if children were having diarrhea or vomiting, there is a higher chance of developing AKI. And the renal replacement therapy, they didn't have to, the conservative management, the renal functions improved, as in our cases too. So the management that we have given is inotrope support, ventilation, methylprednisolone, IV gamma globulin, hepatoprotective measures, low molecular weight, heparin, warfarin. This is all the management that we have given mostly in the MISC group, and the ventilation was required in only around
3 or 4% of children. Invasive ventilation, ventilator support was given in 2 to 4%. And we had given remdesivir in only one child, as we have already discussed. Early initiation in that child actually was found to be effective, but we have no large data to say whether remdesivir may be beneficial or not. And definitely without remdesivir also, all children survived. And our AKI in the category C was 14%, that is severe children admitted to ICU, whereas in the MISC it was almost 21%. And IRGN in association with COVID-19, we actually suspected in 2 children in view of renal dysfunction during the acute COVID associated with hematuria and low complement. The renal biopsy, which was done, actually ruled out IRGN, and second child had MISC and multi-organ dysfunction. As he improved over 7 to 10 days, we didn't do a renal biopsy in that child, as well as we haven't done this complement evaluation post discharge. So to summarize, 625 children with COVID-19 infection were admitted over a period of 9 months. 427 were symptomatic and 39 belonged to category C. AKI occurred in 2.1% of symptomatic COVID. None of the children with category A or B had renal injury. 20.8% of children with MISC had AKI. 25% had stage 3 AKI by KDIGO staging. All were non-oliguric and were managed conservatively. Nephrotic syndrome on immunosuppressive medication was not found to be a risk factor for morbidity or mortality in COVID-19 infection. Immunosuppressive medications were continued in all these children with COVID. Initially, we were thinking that we will not be continuing on MMF, we will be withholding rituximab infusions, we will not be giving cyclophosphamide. But as time passed and more literature started coming from the other centers, we also started using these medications, and we have found that we are not actually increasing the morbidity or mortality because of these immunosuppressive medications. Pre-existing CKD or even CKD5 on dialysis was not found to be associated with a higher risk of severe COVID infection, morbidity or mortality in our series, even though it is a very small series of CKD5 on dialysis. Thank you. We are actually fighting COVID, and mask is there on all our faces. And COVID-19 vaccine is almost there. By Jan, we will be having, and we hope that the bright new world is going to come back. Thank you.
I think, Susan, that was a very nice summary of what all you had during the last few months regarding COVID in SAT hospital. That's quite an impressive statistics of the patients there. And the important fact is that no mortality, no? That is very good.
Yeah,
and,
maybe we
were the fact that if you treat properly, there won't be any deaths.
Yeah, we hope
in
so.
adults, or hopefully also. Except, but only one thing is that we don't have that many kids with comorbidities with who had severe COVID. So that may be one reason why the mortality was a little bit lower.
And also the diabetic population is what is actually contributing to the mortality in the adult, no? We actually don't have we have not looked into that data. We also have children with type 1 diabetes, but whether they are having COVID, we have not looked into. Our endocrinology group has not, I think they have not looked into that data.
There is a question from Dr. Geeta saying, can there be only infection but no disease in most of the kids? No specific drug for COVID was used. So there may be other risk factors for developing severity.
Yeah, we really don't know what is the risk factor, whether it is the immunologic backup that each and every individual is having is the cause for more severe infection or comorbidity that is there. Actually, in children, asymptomatic COVID positivity is actually very high. And so maybe they are having the infection only and no disease. I don't know whether we can just make a statement like that. I am not sure. Prasad.
Yeah, just a few comments, if I may. So the immune response in children is completely different when you compare the immune response in adults. And I'm talking specifically for COVID. And those publications have come out, in great journals, Nature and Science and so on. And so there's a good biological plausibility why children do not get as severely affected with COVID as adults do. In addition to the comorbidities, it's the immune response itself is very, very different. And we've seen the same thing. To be honest with you, in this country, pediatric nephrologists are dialyzing more adults with COVID than kids with COVID. I repeat, pediatric nephrologists are dialyzing more adults with COVID than kids with COVID. And that's because all our adult units are totally swamped. They're all totally overwhelmed. And we're actually calling some of our senior nephrologists out from retirement and saying, you better come back because we need you. So also nurses, so also pulmonologists, so also ICUs. This is a crazy time that we're all facing. But what Susan has observed in SAT is also what we have observed here across the country, which is in the non-ICU kids, the AKI incidence is maybe 1 or 2%. And most of them are pre-renal, most of them respond to fluids. In the ICU, if a patient with COVID, a child with COVID ends up in the ICU, we see rates of about 10% for AKI. But even those, many of them don't need dialysis or renal replacement therapy. And again, the other point that Susan made, which is our immunosuppressed patients, be it our nephrotics, be it all our transplant patients, they are not more susceptible to COVID than the non-immunosuppressed patients. And we have learned at this point to not change their immunosuppression even if they get COVID. So everything Susan has observed is exactly what we're also observing.
I think to a certain extent, adults also, we are not stopping the immunosuppression now. Initially, we were worried, but now we are continuing all that. Unless they have very severe symptoms, then we stop the anti-proliferative agent, like mycophenolate or azathioprine. But anyway, we are jacking up the steroids in that case, so probably they are protected. And we didn't have any serious problems in our transplant adults also, in addition to transplant children. So Kashi sir has asked a question, what is the available data from literature on cytokine storm in immunocompetent children with COVID? Yes.
Yeah. So actually, sir, I have not looked into that data per se. The multisystem inflammatory syndrome that we are seeing in children occurring during COVID infection as well as post-COVID with lot of inflammatory markers which are to the tune of 10,000s and 50,000 like that, and they are becoming really sick. Whether we can actually compare this as the cytokine storm, I am not sure. I have not looked into that data.
I think should we proceed?
Yeah. Shall we proceed with the next talk, Prasad? Elizabeth, ma'am?
Yes, please.
Yeah.
So let me share my screen. Yeah. So good evening to all and good morning to those who are attending to us from the United States. So I'm going to talk about COVID-19 and the kidney in children. It's complicated. I use the term is complicated. There are reasons for that. So before we just start with the case, this is a 14-year-old boy who presented with fever and chills for 4 days with Albert sensorium. He had an erythematous papular rash on the abdomen. He had tachypnea, which was initially controlled with NIV. Somebody's sound is coming up. Can everybody mute their systems if you don't mind? So he had so as soon as he presented to the hospital, he has tachypnea and he had to be put on NIV. And he rapidly went into shock. He was put on 2 inotropes. So we suspected sepsis, septic shock. He was COVID PCR negative at that time. So investigation showed neutrophilia, thrombocytopenia, a little bit of lymphopenia, and the CRP was in the 200s. The blood culture subsequently came out as sterile. But anyway, he was put on broad spectrum antibiotics, meropenem, teicoplanin, and doxycycline. So on the second day, he went into anuric AK, and at the same time, he developed cardiogenic shock. Initial echo, when he was admitted, had showed good LV function, but this became a severe LV dysfunction at that time. Ejection fraction was only around 20%. So he had persistent hyperthermia, respiratory distress. He was intubated, ventilated, and you can look at those inflammatory markers. The cardiac markers, prop T was very high, ProBNP was 4000s, and IL-6 and ferritin were also elevated. His thrombocytopenia worsened, his platelets dropped to the low 30s. And he was put on cholesterol and micafungin because at that time, because the COVID-19 was negative, we did not suspect that he had COVID at that time. He had went into refractory shock with MODS, and he was started on VA ECMO on the third day due to persisting poor ventilation and cardiac dysfunction. And by the time he had gone to anuric AKI and he was started on CRRT, actually we gave him a very stiff dose of CRRT because I think 50 ml per kilogram. And subsequently, he went into quadriparesis and CPK went up to 30,450. He was right now on triple inotropes. On the fifth day, SARS-CoV antibodies were positive. And see, that was a problem there because we did not realize it was SARS in the beginning, and that's why all these complications occurred. Then we gave IV immunoglobulin, we gave IV methylprednisolone, and within 1 week, we were able to improve his respiratory function. His VA ECMO could be decannulated, and he was back on a ventilator support. And he was put on tracheostomy. So before we go with the case, let's talk a little bit about COVID-19, what has happened in the last 1 year. So as we know, it is a true pandemic. All of us are living through a portion of history. But overall, if you look at the children data and what we have seen from the literature as well as what we have seen from presented today, COVID seems to be a mild illness in children. But the number of people affected is huge. So look at the data, 1.2 million children in the USA alone. But hospitalization rates have been low, and the US data shows that about 6,700 hospitalizations and about 133 deaths as of 1 week ago. But what has happened is that more than 99% of the world's children have been affected by the pandemic due to social and economic reasons. So that is far more than the medical problems that have ensued due to the pandemic. And the data are actually uniform. Look at the data all over the world. So if you look at the hospitalizations in general, it's only 1.8% of total hospitalizations in the US. You compare adults with children. And if you look at the percentage children who are hospitalized for COVID, it's only 1.5%. And look at the data worldwide. So initially it was, since the WHO presentation, you can see that these last three, the blue and the orange and this light gray, they all represent children less than 20, actually less than 25 years, but that's probably an approximation. So you can see that the initial percentage when the pandemic started was just about less than 5% of all children were affected. But as the pandemic grows, the number of people who are affected has increased. Now it's about 10 to 15% who are affecting, of all the people who are affected are in the pediatric age group. So the number of children who are affected has actually increased over time. And you look at the Indian data, again, the less than 14 years, so we don't have data less than 21 years, but if you look at the data less than 14 years, only about 0.5% of the total numbers who are actually children. So children are definitely in a minority as far as affection is concerned. In India, of course, this data is probably highly tainted by the lack of proper testing, and children are less likely to be tested than adults, so they're less likely to become positive. So probably we may have a higher percentage, but we really don't know. And look at the mortality data is also uniform all over the world. This is Italian data. So look at the children is about 0.1%. And look at the Spanish data, that is also about 0.6 and here 0.4. So about approximately around 0.5% in Spain. And the New York data is about 0.1% mortality in children. Compared to adults, and as you go up the age, you can see that the mortality is much, much higher in older adults. And if you look at our own center, the data that we had about 100 children admitted with COVID so far, all category B and C mainly. Only 7 of them needed critical care support. Only 3 needed invasive ventilation. All of them were ventilated only for a very short period of time, maybe 2 or 3 days, and then subsequently got over, except the one patient who I've talked about so far. And so far, all of them have survived. My index patient is also so far surviving, but we don't know what's going to happen in the future. So that's about the data all over the world. So if you look at pediatric COVID-19, overall, is it a mild illness? The answer to that is it's complicated. So as we said, the medical reason is not enough. The social and economic reasons are far more important to the lives of children everywhere. The second thing is that general pediatric care has been compromised because those who are with chronic disease, they're not reporting for care. In fact, many of my nephrotic patients and others are not coming back for follow-up also. And some of them have been taking steroids daily for the last 6 months, exposing themselves to a lot of steroid-related complications. So that is also a problem. The small percentage that get complications get them very badly. So that's also a point to be noted. So you have to identify those people those children who are going to become critically ill and treat them early, because then they can improve. So on the surface, it appears to be a mild illness, but definitely it is not another flu. And if you look at the renal involvement as such, the renal involvement is a vast spectrum of disorders in COVID, of which the most serious manifestation is acute kidney injury. So acute kidney injury may occur alone, or it may be often associated with the multi-inflammatory syndrome that we have talked about so far. And you can have also other forms of glomerular disease, mainly collapsing glomerulopathy and thrombotic microangiopathy. Both have been reported in children. So the rest of it, what I'm going to talk about is half of what I'm going to tell you now is wrong, and I don't know which half. It is actually a corruption of an old quotation, but that is true for what? Because we really do not know much about COVID, as Dr. Prasad was saying earlier. So what about AKI? What are the mechanisms of AKI in pediatric COVID? In fact, the pediatric AKI is much less studied than the adult forms, and some of this is actually derived from adult COVID. So AKI may occur in the early phase or late immune phase of the disease. In children, it is very much unlikely that it occurs in the early phase, more likely in the later phase of disease. So you can have either a direct effect due to the virus or indirect effects due to the effect of other components of the viral mechanism of the body. So this is how the COVID affects the kidney. So if you look at the direct effects, these are the main reasons. One is that it affects the podocytes and causes a collapsing glomerulopathy. That's why proteinuria, a podocyte localized. Then it can localize the endothelial cells and produce a endothelial damage. It can form clots, as we all know. It's very well known to form thrombi, microthrombi in the glomerulus, and can lead to the thrombotic microangiopathy, and that leads to fibrin deposit. So this is the direct effects upon the glomerulus. And it can have direct effects upon the tubules also, where it produces inflammation directly, interstitial edema, capillary obstruction due to the RBCs in the pericapillary region, in the peritubular regions, and it produces tubular necrosis and tubular apoptosis. So all these features are direct effects of COVID infection. And you have multiple indirect effects of COVID. So the first thing is the volume depletion, I told you, and Dr. Susan has already talked about this. Volume depletion is a very important factor, and proper volume correction is important. So volume is a very tight balance in this sort, because predominantly it affects the lungs. And in lungs, you want the patients to remain relatively dry. For the kidney, you want the patient to be adequately hydrated. So you should use all types of invasive or non-invasive measures in order to monitor the volume in children, especially, and make sure that they are properly volume replete and not over replete also. That's very important. The second thing is nephrotoxins commonly, and you know that recently some studies have come out saying that indomethacin is probably effective against COVID, and probably this may lead to a rash of NSAID prescription, and which is another important nephrotoxin. Mechanical ventilation, as we know itself, especially when you're using high PEEP in many patients when they have ARDS and restrictive disorders, high PEEP can lead to increased venous retention and increased venous pressure, and that can lead to adverse effects upon the kidney. Then sepsis, secondary sepsis is also a common feature of COVID, and that can lead to AKI, as you well know. Organ crosstalk, Dr. Susan referred to that, and the most important organ crosstalk that we know of is cardiac and renal, CRS, the cardiorenal syndromes. And here it is the effect upon the cardiac failure that causes renal dysfunction. But organ crosstalk can also occur between the lungs and the kidney, between the liver and the kidney, between the brain and the kidney. So all these things can lead to AKI in these children. Rhabdomyolysis occurs very commonly in patients with MIC especially, and this can lead to AKI, as we very well know, pigment nephropathy. Cytokine storm. Cytokine storm is one of the most abused terms as far as COVID is used. Everybody blames cytokine storm for everything. But if you look at the data, actually, the cytokine storm in COVID is not to the extent that occurs in sepsis. The levels of IL-6, ferritin, and all that are about 10 to 20,000 times less in COVID when compared to sepsis. So we really do not know whether it's the entire cytokine storm which occurs in COVID, or maybe the effect of specific cytokines, or maybe the effect of viral cytopathic effects, which virus can affect any organ which produces ACE2 receptors, for that matter. So cytokine storm is there, but as far as we know, we do not really know whether it's really a big contributor to this. And then you have endothelial dysfunction, which is also a feature of COVID, as we know, and COVID affects endothelium in multiple ways. You have COVID affecting coagulation. It's been noticed very frequently. Thrombotic events are extremely common, venous and arterial thrombosis, as well as increased anticoagulation requirements also. And lastly, the immune dysregulation, the impaired immune response. And that varies between children and adults. So all these indirect effects are there, which act upon the kidney and produce AKI. And again, if you look at it, most of the children who have AKI develop in association with other features of hemodynamic compromise and shock. but rarely it can occur with normal hemodynamics. Of course, as far as treatment is concerned, there is no difference between AK in COVID or AK in other situations. But one good thing is that if the child recovers, usually they recover. And CKD is probably not an important component in this type of AK. And steroids and remdesivir we are using effectively despite the negative results of WHO trial. And probably remdesivir used early has been effective. We have not used remdesivir in children so far. They are not required to use remdesivir, mostly in adults mainly. Some specific features of dialysis that dialysis is instituted based on standard indications. You can use hemodialysis, you can use CRRT. Peritoneal dialysis has also been used, but data is scarce in the pediatric population. Not much of dialysis in the pediatrics so far. And dialysis providers need practical solutions more than the actual dialysis prescription is the practical solutions to peculiar problems of using full PPE and the logistics of transporting dialysis machines and portable RO machines and all that. And if you're doing peritoneal dialysis, it may be preferable to insert PD catheters bedside. Again, logistic reasons, transporting a child with COVID to the ICU or to, not to the ICU, into the operation theater and using laparoscopy and other facilities may be more of a problem in these children. But the dialysis prescription, as I said, is the same, whether it's a COVID patient or any other sick patient for that matter. Anticoagulation, as we already heard, that most published literature focuses on increased anticoagulant requirements for COVID. Actually, we have seen a lot of coagulant problem, MI, PT, pulmonary thromboembolism, strokes in adults especially, but we are not required to use more anticoagulation. We had many dialysis patients who required dialysis, and we use the same anticoagulation in them, even when they had active COVID infection. We have had AKI due to COVID, and we use the same anticoagulant requirements. So something is different in different parts of the world. So we are not using the increased anticoagulation in these patients. But at the same time, these people are prone to coagulant events such as arterial and venous thrombosis. And then MISC, as you know, even as late as just 1 month ago, the ICMR has declared that there has been no case of MISC or Kawasaki disease in children with COVID. And we know that that is wrong. Almost all of us have seen MISC in children in well before this announcement came out by ICMR. So just to recapitulate, the case definition for MISC in children involves an individual aged less than 21 years presenting with laboratory evidence of inflammation, evidence of clinically severe illness requiring hospitalization, at least 2 organ involvement. It may be cardiac, renal, respiratory, hematological, dermatological, neurological, or gastrointestinal. Then with no alternative plausible diagnosis, and must be positive for current or recent SARS-CoV-2 infection. You can use either RT-PCR, you can use an antigen test, or you can use serology, as we used in our patient. Or it may be a COVID-19 exposure within 4 weeks prior to the symptoms. So that is the definition, case definition for MISC. And if you look at the MISC data, we don't have good data for all over the world. I could not find a lot of data, but there is good data for the United States. As of October 30th, there have been 1,163 cases, but only 20 deaths. So, and if you look at the New York data, which is published in the New England Journal somewhere in August, out of a total of 99 patients with MISC, only 10 developed AKI. And out of these, 3 died. So you must know AKI is one of the things that of all the people who died, all of them had AKI. So AKI is one of the most important factors which may lead to death in these children. So we must be able to treat that properly. And those 3 children also did not receive any immunomodulatory therapy, which is also a very telling statement that that is probably the cornerstone to success in MISC. So just to summarize about MISC and AKI, AKI is a common feature of MISC when severe myocardial involvement is present. Otherwise, AKI is not a common event. As I said, there's only 10% of cases develop AKI. And the reason for AKI is hypotension and shock and the type 1 CRS, which occurs in these patients. So if you treat properly with immunomodulatory therapy, disease is a good prognosis, even when severe. But AKI means severe hemodynamic compromise in the children. Probably we have let the disease go too far. So just to emphasize that point again, we should give aggressive immunomodulatory treatment as early as possible. And that is the key to treating MISC in children. The next type of involvement is collapsing glomerulopathy. That is a very interesting type of glomerulopathy, which we have seen that the list of conditions which cause this has grown over the years. It's become almost impossible to remember a huge table of conditions. But to add to that is now COVID-19. So here it is present. All these patients had nephrotic proteinuria. Hematuria was also seen. renal dysfunction and AKI are seen, but all seem to improve over time, and some recover to completely normal. So that's the difference between collapsing glomerulopathy due to COVID. The prognosis seems to be better than other conditions. And this is derived, these pictures are derived from a series of 8 cases which were published in the JAS in November last month. But none of them were in children actually. So how does collapsing glomerulopathy occur? It's probably due to a direct effect of virus, because virus can enter podocytes which express ACE2 as well as the receptor, the transmembrane protein RSS, TMP, RSS2. And both are required for viral entry into podocytes. And the only other cells in the kidney which express more levels of ACE2 are the proximal tubular cells. And therefore, these patients can also develop an associated AKI along with the, or ATN, along with the presence of a collapsing glomerulopathy. In one study, they have seen virus particles on electron microscopy. Another study they have not seen. And there are several pathologists who have cautioned against interpretation of viral particles in EM, because many of which what seems like viral particles may not actually be viral particles, or maybe just cytokine production or interferon-induced cytopathic effects. So we are not, so still the jury is out on whether these are actually viral particles, but there is very strong reason to suspect that these could actually be due to viral infection. And in people of African descent could be due to APOL1 susceptible genotypes. In fact, in this case series was published, all 6 of them had susceptible APOL1 genotypes. But we have seen this in our country also, and probably it may not be related to APOL1 in our country, but we are not really sure. We should do the genotypes and then see. So the lesson learned from this collapsing glomerulopathy is that the virus or the immune reaction of the virus specifically targets podocytes, which seem to be the main focus of damage. They also target the proximal tubular cells in these cases. And both are seemingly, they seem to have a high level of probably maybe due to viral cytopathic effect, because it affects the high level of ACE2 expression in these 2 types of cells. But that is my own opinion. It is not borne out by the literature so far. And the thrombotic microangiopathies are also a feature of COVID, and this has been reported in children also. And you have seen a lot of complement cascade abnormalities in COVID-19. Mainly, it affects the COVID-19 activates directly both the alternative and lectin pathways. So you find high levels of C3A and C5A in these children, and also C5b9 pathways. But when the complement begins activated, there can be low C3 levels in these children also. Because of the activation of C3, C3 might come down in these patients. Activation of macrophages. So not only that, they activate other portions of the immune system. Macrophage activation will release tissue factor, and this will activate the extrinsic coagulation pathway. So there is one mechanism of hypercoagulability in these conditions. Another mechanism is that they activate all sorts of danger-associated molecular patterns and pathogen-associated molecular patterns. And therefore, all these, along with cytokines, all these can enhance coagulation, these factors. Secondly, macrophages will release cytokines which activate neutrophils. Neutrophil activation will cause neutrophil extracellular traps. And these nets, they can cause platelet activation. And you can find platelet thrombi in the capillaries. And as you know, this platelet thrombi can be the nidus for capillary thrombosis. And therefore, this thrombosis will lead to schistocytes and breakdown of RBCs and all the features of thrombotic microangiopathy. So, thrombotic microangiopathy, there is a very logical pathological explanation or pathophysiological explanation to the development of thrombotic microangiopathies in COVID-19. And in case reports, there was a 14-year-old girl who was treated with COVID-related MIC who did not respond to anakinra and IV immunoglobulin. She showed low platelets anemia and improved complete remission after 4 doses of eculizumab. So not only that thrombotic microangiopathy, not only that is due to complement, but probably can be treated by eculizumab. So for demonstrating whether a patient will respond to eculizumab or not, it's better to check a C5b9 level. So if a C5b9 level is high, probably they will respond to eculizumab. And therefore, using that paradigm, they have used eculizumab in severe respiratory COVID without evidence of thrombotic microangiopathy, and again shown success in some patients, but not in others. So we are not really sure, again, whether this has a role or not. And you must remember, eculizumab is not a drug which can be used left and right. It is very, very expensive and has significant side effects. What are the other COVID-related renal diseases which can occur? So there have been one case of acute interstitial nephritis which was published, and this is probably again believed to be due to a direct cytopathogenic effect of the virus. One case of proliferative crescentic GN was reported from Iran, but this was actually commented upon. They had presented the pathology slides, and one other person commented that these crescents which are demonstrated may actually be pseudocrescents. But the authors replied back saying that they had markers of crescents which were positive on the immunofluorescence, on the immunopathology. So there is one case of proliferative carcinoma to GN. One swallow doesn't make a summer, but probably it may be related to this or may not be related to this. Then post-transplant allograft dysfunction, there are multiple case reports when probably the long-term outcome is good in these patients. Many of them recover. One case of uncausated vasculitis was also reported, but we do not know. Actually, it is not one case, it was 2 cases, which was reported in this particular article. So maybe it is related, maybe it is not related. When you have so many things happening, these patients can develop an associated uncausated vasculitis, which may be related to COVID, but may not be related. And both these patients were treated with cyclophosphamide and they did well. So that is also interesting because usually people are using rituximab rather than cyclophosphamide in these conditions. And anything else you can think of, probably maybe associated with COVID in the kidney, which we still have to describe. So coming back to our child, so after almost 2 weeks, he became hemodynamically stable. Sensorium was still altered. Child had little response. He was practically mute and seemed to have a locked-in syndrome type of effect. But after 1 month, he completely came off dialysis. Renal function normal. Urine output is normal. In the meantime, he required multiple courses of antibiotics, antifungals, micafungin for sepsis, and he improved. He was weaned off ventilators solely. He's now on intensive physio. He's on PEG feeds. He's still in hospital after 2 months. But he has slowly started recognizing his parents and slowly is coming out. So hopefully we will have a good outcome in this case. So thank you all. I hope you enjoyed my presentation. Review of my hospital looking in non-COVID times.
Thank you, Sadish, that was a wonderful presentation. And now it is open for discussion.
Stop screen sharing.
Any questions, comments?
A very comprehensive review and overview. Again, showing that we don't know more than we think we know. Still a lot to learn about this disease. So just as an aside, the Infectious Disease Society of America will start a 2-year postdoctoral fellowship program called COVIDology. COVIDology, that's a new super specialty that is going to be started. This disease is so complicated, and even with a vaccine, I think we're still going to be dealing with it for many years.
Yes, I think that's very important because it's not like just a respiratory disease, a multi-system involvement, and so many other features. We still have a lot to learn about the virus. Anybody else? Any questions?
If there are any more questions, there are no more questions. Shall we wind up?
Yes, thank you very much for everybody to having presented.
Yeah.
Thank you.
And I call upon our president of the Indian Academy of Pediatrics Trivandrum branch, Dr. Bennett Salem, to give concluding remarks.
Thank you, Dr. Susan. Thank you very much for this occasion. And first of all, I thank International Society of Nephrology, Trivandrum Nephrology Club, Cincinnati Children's Center, Department of Pediatrics Nephrology, Government Medical College Trivandrum, and all the faculties, Elizabeth Madam, Vimala Madam, Susan, Dr. Susan and Dr. Sadish, and Kachi Sir, and all the delegates, and Dr. Prasad, who participated from New York. And it was an excellent discussion. Especially, we are very proud that in Trivandrum, we got 2 major hospitals, SAT Hospital and KIMS. Even though we treated complicated cases, no death till today. And only 625 children treated in SAT Hospital is not a less number. It's a major number only. And even though we treated a nephrotic syndrome case with the COVID, but no complications occurred. So we are very fortunate in that. I have seen, I am a member of Death Audit Committee of State, and we had one death of a child, 13-year-old, actually without any comorbidities. We don't know what happened, but I expected that thing from nephrology also, but nothing happened. Anyway, it is thanks to all for any other complications like that. And we are waiting for more programs like this, and IAP is very fortunate to have in association with this organization. Thank you very much. Thank you.
Yeah, we will conclude and
yeah.
I wish you. Yeah, so wish you all a new year 2021. It is possibly good. And we are we all have the vaccine and we all will be out out and traveling and meeting each other, not on the virtual platform. Yeah, good night.
Before just one last question, there some patients on maintenance hemodialysis are not becoming negative even after 2 weeks. What do you suggest for treatment? Actually, once that symptoms come down, becoming negative is not much of a problem because they can remain positive. There are even patients who have been positive for more than 60 days after diagnosis. So really, once the symptoms are over, you need not do anything, just leave it alone. And one thing we suggest is that don't do an RT-PCR or something out, only an antigen test, because PCR may not become negative for a long time. So you should do only an antigen test after. The antigen test is negative, is not infective, nothing more needs to be done. We can close.
Yeah, good night.